Our speakers today. We're spotlighting eating disorders in women of color. The research literature and conversation on eating disorders in Black and brown women is sparse, and yet eating disorders can affect anyone and are on the rise. Today, we will discuss disparities in diagnosis, differences in vulnerabilities, and lack of access to culturally sensitive treatment for Black and brown women. While the mission of the Schubert Center is to bridge policy, research, education, and practice to improve the lives of children and adolescents, we are mindful that eating disorders affect people across the lifespan and their families. Today's event will begin with a lecture from Dr. Rachel Goode, followed by remarks by Dr. Kelly Bhatnagar, who will focus the discussion on youth in our local community. We will then move to a brief panel discussion and then open it up to questions from you all. So just some general housekeeping, keep yourselves on mute, and feel free to drop your questions in the chat. Thank you to our campus partners, the Flora Stone Mather Center for Women, the Office of Diversity, Equity, and Inclusive Engagement, and the Jack Joseph and Morton Mandel School of Applied Sciences. Dr. Rachel Goode is an assistant professor in the School of Social Work and an adjunct assistant professor in the Center for Eating Disorder Excellence at the University of North Carolina at Chapel Hill. She received her Ph.D., her MPH, and her MSW degrees from the University of Pittsburgh. Her research interests include developing, implementing, and evaluating interventions to treat eating disorders and obesity. Additionally, Dr. Goode is a licensed clinical social worker and has practice experience with the treatment of eating disorders and obesity among clients in university counseling centers and community-based mental health agencies. Her ongoing projects include an NIH Career Development Award to develop a culturally relevant digital health treatment to treat binge eating and obesity in Black women. Dr. Goode, we are thrilled you are joining us, and you can go ahead and share your slides. You're muted.
Can you all hear me now? Yay. Okay, great. I'm just grateful to be here. That's what I was saying when I was muted. I'm grateful to be here with you all, just for us having this conversation, because eating disorders certainly have changed, our awareness of them, the impact of them, and especially since COVID-19. So I'm just looking forward to our discussion today and grateful just to be with you all. So I also wanted to, let you all know a little bit more about me and my work and what I do. I direct, it's called the Living Free Research Lab at UNC Chapel Hill. It's a lab I started, and our work largely centers the experience of disordered eating in populations of color and those experiencing poverty. And so it's given me a great opportunity to begin to kind of fill in the gaps of where our research literature is. And so my team and I, again, it's a great honor that we get to do this work. I also come to you all as a key content expert with the National Center of Excellence in Eating Disorders. And so if you are a practitioner, someone who's wanting to learn more about eating disorders, this is a great place where you can get free trainings, because often folks don't feel comfortable when they are talking about eating disorders. We don't get a lot of knowledge in them in our clinical training programs often. And so individuals, there's a lot of opportunities, right, to create spaces to learn. And so I teach here in part of the center. And so it's just been a great opportunity for me to continue to expand my awareness and my knowledge. And so some of my current research projects, we're always doing something. And so we're looking at developing digital health treatments, improving treatments for diabetes self-management in Black adults with type 2 diabetes. We've learned that eating disorders are prevalent as well in type 2 diabetes, binge eating. And so we're examining that and seeing what we can do to develop alternative treatments, as well as considering non-dieting interventions in the role of obesity treatment. And so I have really enjoyed, this part of my career. So today we are going to do a couple of things. One, we're going to just describe what we know about eating disorders in the landscape and begin to create some awareness about some of the challenges and access and treatment retention for Black and brown women. We're also going to discuss relevant factors in the development of eating disorders, which might be a little different than what you anticipate, and then some strategies for culturally relevant assessment tools and the treatment of disordered eating behaviors. So I always like to start with this next slide because I think for many of us, we have a lot of ideas. And even if you just take a minute to think about some of the ideas and what your early awareness of eating disorders, where it came from, where you got your education. I remember the after school specials. I might be dating myself a little bit, but I know some people here remember the after school specials, and they would usually profile a white adolescent young woman who was dealing with anorexia nervosa or bulimia nervosa. And so I remember watching those as a teenager, just being like, wow, it was an experience for me, but it got me interested and helped me understand. But other than that, I didn't have any other education. So that was really where I learned about eating disorders at first. And so one thing that I hope you all will leave this presentation knowing, eating disorders can affect anyone. So many have been harmed because either they don't fit the stereotype, or people don't assume that they could have disordered eating. They don't think they can have disordered eating because we think it looks like one thing, and it doesn't. And I'm hoping that this next generation of research will begin to reflect that. Also, you cannot tell if someone has an eating disorder just by looking at them. So many people who maybe don't fit an idea in our mind, often associated with anorexia nervosa, meeting a weight standard, they get bypassed. And we'll talk a little bit more about that in our presentation. And these are just things that we miss, right? These misconceptions. And so, but what I want you to know more than anything, it is possible to recover. And so I know some of you might have struggled with disordered eating, and it's something that can feel like it'll be with you forever, but it is possible to recover. And I'm going to do my part as a researcher to continue to help us expand our knowledge and how we're going to help create treatments and interventions so that we can make things better for folks managing disordered eating. So here I list when you think about eating disorders, what we know and what is currently in the DSM-5. And so you see the three first: anorexia nervosa, bulimia nervosa, binge eating disorder. Those are probably the ones that you've heard the most about. With anorexia nervosa, that is really predominantly our research literature has the most information about anorexia nervosa. But bulimia nervosa and binge eating disorder, and I'm going to give you all I'm going to go through quickly because there's just to give you all some insight. So anorexia nervosa is often known where folks are having restrictive eating behaviors. And so this has the highest mortality rate of any psychiatric disorder. Okay. And so there's different subtypes: restriction or binge eating, purging subtype. But what's most common is there's restrictive eating behaviors that typically result in low weight. Not always, but typically result in low weight. There's also bulimia nervosa and binge eating disorder. And so both of these, what they have in common is the presence of binge eating episodes. The difference is that in bulimia nervosa, it's accompanied with purging behavior. So individuals might use laxatives or might vomit to get rid of the food. And so then currently, when I just looked in the literature, the most common eating disorder per the DSM-5 is called Asst, right? And so that stands for other specified feeding and eating disorders. And so those are, you think of folks who kind of fall in the gaps, and you can see how it would be very common because there's so many folks that we're seeing that might have elements of disordered eating behaviors, but they don't meet the diagnostic criteria, right? And so we are recognizing and making room for those, and we're continuing to learn that it varies, and we still don't know everything we need to about disordered eating behaviors. Avoidant restrictive food intake disorder, that is disordered eating where an individual might fail to meet nutritional needs or has extremely picky eating behavior. And then pica is disordered eating where an individual eats items that aren't thought of as food with no nutritional value. And then rumination disorder, I don't see it on the slide, but rumination disorder is disordered eating where an individual frequently regurgitates or re-chews food, and they might swallow it or they might spit it out. And so even just by that explanation, I'm sure many of you might have heard of disordered eating behaviors that you weren't aware of. and recognizing that, oh my goodness, you might know someone who's struggling with disordered eating. And so it's all around us. We're likely have someone in our lives who is managing disordered eating behaviors. Per the top 3 eating disorders, binge eating disorder is the most common diagnosed eating disorder in the United States. So this is an eating disorder where folks have the binge eating behaviors. So they're eating a recurrently large amount of food, and that's accompanied with the loss of control. So they feel like, even though I want to stop eating, I can't. And so this is really something where we're recognizing it's pervasive, but our research literature doesn't match this, since most of the emphasis in our research literature has been on anorexia nervosa. So we're going to have to kind of catch up a little bit, because we're recognizing that more and more people, especially when BED was formally recognized as a diagnosis, more and more folks are navigating this eating disorder. So I think one of the first things when we consider eating disorders, I talked about the image, right? And so these images are what I remember seeing, images like this on who struggles with eating disorders. And it began to put forth that narrative of who, when we say eating disorder, who we're talking about. But when you think about the harms of this, that means anyone who does not look like this, their disordered eating won't be recognized. The truth is that we all, across genders, across sexual orientations, across racial and ethnic groups, we all struggle with disordered eating, especially being in a nation that has had so much emphasis on weight. It's in our water. And so it makes it very, very easy to struggle with disordered eating. When we look at what we know in the research beyond some of the stereotypes, just like I said, binge eating disorder, the most common eating disorder across racial and ethnic groups, what we see is that the rates of binge eating, it might be similar or higher in certain racial and ethnic minorities compared to whites. And then we see the impact of food insecurity. And that's something that we are just learning about, I'd say, in the last 5 years, but seeing that those who are experiencing the highest levels of food insecurity, they have levels of binge eating and eating disorder pathology. We do see that anorexia nervosa, the risk is significantly lower for Black and Hispanic adults compared to white adults. And then there's no racial differences in the prevalence of lifetime and 12-month rates of bulimia nervosa. So this was a study that was in over 36,000 individuals. And they looked across these folks to determine the 12-month prevalence of DSM-5 diagnosed anorexia nervosa, bulimia nervosa, and binge eating disorder. And so I highlighted this just so you could see that when it comes to anorexia nervosa, when we look in this sample, they had more white participants. It's still small numbers, but more white participants. And then bulimia nervosa, and again, just with there weren't any significant differences with bulimia nervosa, even though these numbers are higher, it can be a little bit confusing. And then binge eating disorder, that's where you see higher rates of that in non-Hispanic Black and Hispanic adults. And so what I think there's also evidence on is just the role of, risk factors, right? What are the things that might cause someone to risk developing an eating disorder? And are there differences across race? So this study was examining that. And so 2 things, they only saw 2 differences. One, Asian Americans had significantly higher thin ideal internalization, meaning there's a body type size that is preferred, and the thinness one is often the one that is preferred than African Americans and white Americans. And then African Americans had significantly greater BMI than Asian Americans. So those are the only differences. But you see here, no other significant ethnic group differences were found for thinness expectancy, body dissatisfaction, dieting, negative affect, overeating, fasting. And so what I want you all to take from this is that we have more in common than is different. Okay. And yes, there might be some differences in some of the risk factors, but we really all of us are at risk very easily for the same risk factors, likely because we're all in the same society, Western society, here in the United States. And that and we are sharing a lot of the same risk factors. So these things are affecting, and we are all at risk. Also, when we consider just the prevalence and the growing issue of eating disorders, look at this chart with me, you all. You see, this is the evolution. So these are between 2000 and 2018, they see the point prevalence of eating disorders began to increase. So this bar is kind of the weighted average. And so the weighted means. And so you see over time, it has increased. So from 2000, we have 3.5% to 7.8%. And what we know is that there's so many more people who aren't really captured on the slide, right? We know that eating disorders, folks often aren't going to get help. So we recognize that the data doesn't really encompass the fullness of the problem. So one thing I think when we're thinking about eating disorders in Black and Brown women, one thing is to realize that the factors that might affect the development of disordered eating, we might have some alternative things in addition to some of the desire to, they call it the over-evaluation of weight or shape. And so what that means is that when folks usually, that their fear of gaining weight, fear of getting fat, overemphasis on their body type, we have seen in the research literature is that's one thing that has affected the development of an eating disorder. However, what we see in Black and Brown women across the literature is that there are alternative views of shape and weight. Not to say there's not norms, but there's more flexibility in bodily standards. And so I think that has been used historically as to say, oh, that's why they don't have eating disorders, because they don't struggle with that same desire for thinness. However, it's different. And we may not have that same desire, but there are certain body norms that folks are trying to reach, and it's impacting them. Also, we see that eating disorders may arise as a strategy to cope with stressors and trauma. We also see that folks may not even be aware of eating disorders due to the previous stereotypes, and that also might affect the clinicians and doctors that see them. And then we have to consider the meaning of food in the context of family and community. So I'm going to share with you a brief vignette of someone talking about their experience with disordered eating.
As a Black woman with anorexia, it's a different experience because I not only have to kind of deal with all the eating disorder symptoms that are already there, but I have to deal with how it relates to my racial identity. Knowing that my body as a Black woman is never going to look like a white woman's. I am not going to be underweight due to muscle mass and bone density. And so having all of the symptoms of someone with anorexia and really struggling, but sometimes not getting treatment because I'm not underweight, so I can't be admitted places or have an official diagnosis. Or if I do have the diagnosis, still feeling so much denial about it because I have a voice in my head telling me that I don't have this, or that I'm not sick enough, I'm not thin enough to be anorexic, but also having the outside world not really be able to see it either. It feels isolating. It feels isolating knowing that this isn't something that a lot of Black women have shared their stories of having anorexia and being somebody who deals with that. It feels like I'm sort of in between, like I don't get to be a Black person, but I'm not a white person either. I just kind of am stuck in this lonely place. And I'm not really sure where to go from there. When I talk about it in treatment, most of the doctors are white, and so they don't really understand what it's like for me from a cultural perspective. They can be educated about it, but truly getting it, to find somebody who really gets it, is hard. So it just feels very alone. I would say to treatment providers and clinicians to not assume that because somebody looks a certain way that they have a disorder or not. A lot of the time, Black women it's assumed that they don't have an eating disorder, anorexia, bulimia, binge eating disorder. It's not even screened. So I would just say that to remember that eating disorders don't have a face. They don't have a representative. They can be in anyone, and they don't discriminate. And so in the world of treatment, we shouldn't either. We should look at it, the diagnosis and the eating disorder, for what it is, and see that it can affect anybody, and treat everyone who has them, because everyone deserves help. Everyone deserves to be seen, no matter the body that they're in or the skin color that they have.
Thank you. I always, whenever I see this young woman being so brave and sharing her story, one thing that her words stick with me, and recognizing, one, you cannot tell by the way someone looks, and it's on us. I think of myself as a researcher. I'm in this too, and I have to create the knowledge. I get to create these things because we don't have the knowledge. That's one of the reasons why folks are making these misconceptions. But we are going to move forward, and we're going to work to do better. So one of the things that I think is important is to think about, okay, so we have an idea, a stereotype of the factors that contribute to disordered eating. And for, again, the white majority, that has been, but based on the research literature, what they've seen as the predominant factor, that over-evaluation of weight and shape. However, what we're recognizing for Black and brown women, there's some other factors, right? And so I'm going to go through a couple of these so that you all can get an idea and consider how this might be a little different. So the first one is food insecurity. And so this, again, might seem a little bit strange, and you might wonder, how is food insecurity, especially in the United States? So 88% of our country would say that they have enough food to meet their nutritional needs. But for that 11%, that 7% of those would say they have low food security, right? And then another 4% would say they have very low food security. And so what we see is that low food security and very low food security are associated with binge eating disorder. And so with participants who have the highest rates of food insecurity, so that means adults who have hungry children in their household, they endure significantly higher levels of binge eating, overall eating disorder pathology, worry, weight, self-stigma, compared to those who had lower levels of food insecurity. And we also are realizing that among SNAP recipients, the Supplemental Nutrition Assistance Program, what we're seeing, and they call it the food stamp cycle. And so SNAP benefits are, for those who aren't familiar, are typically allocated once per month. And so what we've seen in my group, we just did a study where we were talking to SNAP participants. And what we learned is that there's about 3 weeks of the month where money and food is available. But for that 1 week period, folks are restricting their food eating because they don't have enough money for food at that time. And so they're restricting. And what happens though, when the access to food is restored in about 1 week, we might see that folks overeat when the benefits are restored. And so these patterns of undereating and overeating might relate to binge eating episodes and might increase snacking behaviors. So we're learning, again, this is probably within the last 5-7 years, we've been learning more about poverty, food insecurity, but we see how this influences the development of disordered eating. We also see the role of trauma, right? And so just traumatic event exposure is associated with higher eating disorder pathology, especially trauma in childhood. Okay. And so in a recent systematic review, what they saw was that those who experienced childhood abuse, whether it be physical, sexual, or emotional, they had increased risk for the development of bulimia nervosa and binge eating disorder. Alternatively, we also have the role of racism, discrimination, and microaggressions. And Black and brown women have an experience in this country where they are facing multiple oppressions, whether it's racism, sexism, classism. And so that intersectionality creates a landscape where it's a stressor, right? These stressors might increase what we see in the literature. It might increase the risk of disordered eating. as well as that acculturative stress. So let's say these individuals who are trying to fit into the majority culture, they might experience alienation, a lack of belongingness. And so that might lead to desires to fit in more. And so it might create an opportunity to assume some of the dominant cultural norms related to body size because they may be feeling excluded by body size. And so we're seeing that folks who are in spaces where they are, one of only a few folks of color can sometimes feel an overwhelming amount of acculturative stress. And that can be associated with eating concern, shape concern, weight, drive for thinness. And so there's still so much more we can learn about this. Also, the strong Black woman syndrome. And this is something that, again, it's known for Black women, but I think we can see it across other people of color groups, this desire, this sense that you just have to kind of be able to endure all things. You might have difficulty accepting help from others, need to be independent, and so what happens is when folks have, and they struggle with the strong Black woman syndrome, they are more likely to have less self-compassion, and that less self-compassion can lead to increased emotion regulation difficulties, eating for emotional reasons, and then ultimately lead to binge eating. So as you see, just as I went through those factors, these are a little different than what we see typically, but just because we don't know that much about them doesn't mean that they aren't there and aren't reasons why we're seeing the development of disordered eating in these groups. So this is another study where it was in 775 adults, right? And so they were looking at the trajectory of how disordered eating develops. And does it look different across racial and ethnic groups? And just to orient you to the slide, so this orange is the age of onset of binge eating disorder. The green is age of onset of binge eating. The blue is age of onset of obesity. And so just to walk you through the model, what these researchers found is that folks usually developed obesity, and then again, you think about what our culture promotes, right? Dieting. And then dieting led to probably feelings of feeling restricted, okay? And so what we know is that when restriction is present, it almost breeds binge eating. It's just a rubber band effect. And so binge eating will come, and then that led to binge eating disorder. And so what we see, again, when we look across the races, what we see is that for white folks, they develop obesity, again, at an earlier age. And so you see a much longer time with binge eating disorder, longer rates of binge eating. But when you look at Hispanic and Black adults, you see they might develop obesity a little bit later, but then we see that there's much shorter periods where they are dieting, binge eating, and that going to binge eating disorder. So their severity they go much quicker through the pathway. And we're not entirely sure of why that is, but we're seeing that I think one of the reasons is that by the time folks are getting help for these things, it's later because of all the stereotypes, all the barriers to care. And so folks aren't really getting the help that they need. And so by the time they're seeing our clinicians, it's much, much later and also we're getting the data a little bit late too. What we see though, when entering treatment, the differences, I remember I said this before, Black Americans will present with higher BMI, but similar weight, shape, and eating concerns, and similar or more frequent binge eating episodes, okay? So they're just in a different size body. And I think that has been one of the barriers because a lot of our disordered eating cutoffs, criteria are based on weight. And so more and more researchers are calling to attention that we cannot, and maybe that's not the best way for us to really characterize the presence of these behaviors. We also see that, when just the differences in compensatory behaviors, we recognize that among Black and white participants, we see in this study, they were looking at just trying to, just how Black participants compared to white participants with bulimia nervosa. And what they noticed was that Black participants were much less likely to engage in self-induced vomiting, despite being just as likely to meet criteria for bulimia nervosa. So it's just an overview of just knowing there are differences, but a lot of similarities, and we have to remember that in our treatment approaches. I also wanted to just bring to your attention COVID-19. I know we all feel like we barely survived. We got through COVID-19, but oh my goodness, it had such an impact on our eating behaviors, on folks who are navigating disordered eating. What we see here in this chart is that when folks were when folks were managing disordered eating behaviors, we saw that people were, it was increasing. So this is a chart of folks in the US and the Netherlands, okay? And so when they were asked what has been the impact of COVID-19 on their eating disorder behaviors, they reported, increasing their binge eating, restricting their intake, engaging in more compensatory behaviors, feeling anxious about not being able to exercise. And what we saw when we think overall about what COVID-19 did for eating disorders is this is a theory of kind of what folks were recognizing. One, we were really exposed to the media. Our normal activities, our social support was disrupted. Folks were isolated. Folks had, modified physical activity behaviors, and there was just lower access to treatment and care. And so what they noticed is that as those combined, as well as the fear and the negative affect, and as those combined, that increased eating disorder risk and the symptoms. And so my team, we did a study in Black women who reported binge eating. And we looked at, just kind of what their experience was. And so for the sake of time, I'm going to go a little quickly through this data. What we noticed is that from their perspective, they were feeling like all these women had binge eating episodes, and they were about 45 years of age. They reported that they were struggling with just lack of structure and routine, increased loss of control eating, limited food availability, using food as a coping tool. One of our participants said this: I find myself eating ice cream and cookies 2 or 3 times a day and bedtime, which are things I never did before COVID. Before COVID, I could eat a bite of any dessert and be completely satisfied. Since COVID, I've wanted to eat the whole dessert. That's different. That's very different. And I have been this way for years. When it came to dessert, one bite, enough, satisfied, done. Since COVID, I'm not satisfied with anything, and God, it feels like I'm never done. And so I think that just highlights what the people were experiencing. Everything was changing, and just the challenges that they were navigating. And so when we put it all together, what we noticed is that, when we thought about, kind of like a grounded theory approach to looking at the data, we saw that they were increased stress, food as a coping strategy. There were increased eating due to food being available. This data was collected early while we were doing the quarantine. And so if y'all remember, we were going to the grocery store, we were stockpiling because we didn't know how long we were going to be home. Folks had lack of structure and routine, and then they had limited food availability. So they were purchasing foods that they don't normally eat. And what they noticed, increased lack of control around food. So just as we think about some of the challenges that we're having with disordered eating, one, there's disparities in treatment access. And what we see are that Black Americans are less likely to receive treatment for disordered eating and more likely to drop out of treatment. This was just a study that was looking at entering treatment for weight problem versus an eating disorder problem. And we see, and this data is quite dated, but this study is often an indicator of we still see these realities, is that the gray is white women, and then the pink is, the gray is the Black women, and the pink is the white women. And what we see is that the white women were, 3 times more likely to enter treatment for an eating problem. When we think about lifetime service utilization for, adults with a history of any eating disorder, anorexia nervosa, bulimia nervosa, or binge eating disorder, what we see is that there's just significantly higher rates of service utilization for white folks compared to Black, Latinx, or Asian folks. And when we look at the reasons for not seeking eating disorder treatment. This was in a study of about 26 multi-ethnic women. What we noticed, 29 women, is that financial difficulties, lack of insurance kind of came to the top, not knowing about the resources, shame, discrimination, counselors not of the same ethnic background. These are things that we're seeing are kind of standing in our way for our women of color really being able to get the care that they need. So this was a study of clinicians, who identify as therapists who treat women of color. And so what they noticed, and if we think about their perspectives, is that in order to improve outcomes for this group, they saw that their clients were battling shame. That was a barrier to them getting the help they needed. The therapists felt like they didn't have the tools to really help them, right? They wanted to offer diverse treatment models. They didn't really have them. You didn't feel like they had the time to really get the supervision and care they need to be their best. They wanted to reflect and think about what they were learning. They were afraid of getting it wrong. And then they didn't have the tool, they wanted to recognize and pull in the experience of working with cultural difference and understanding the different functions of an eating disorder and addressing how culturation might play a role. And I love that we're hearing from the therapists because they're giving us our guidebook for how we're going to be able to move forward. However, another challenge that we're seeing is that I think because of the stereotypes, when eating disorders show up in clinicians' offices, they don't always recognize them in Black and brown women. So this was a study done where psychologists were presented with identical case studies, okay? And so they were read all these symptoms, and then they were asked to identify if the person's behavior was disordered eating. And so 44% were able to identify the white woman's eating behavior as problematic. And then 41% identified the Hispanic woman's eating behavior as problematic, but only 17% identified the Black woman's eating as problematic. And so we see our clinicians have said they don't get this training. And so they're often our first line of defense. And we're going to have to work, overtime to make sure that they won't be able to say that in this next 10 years. And so when you think about some of the reasons for this, what we realize is that the patient is not underweight. Clinicians may perceive eating disorders, again, based on some of those stereotypes. It's only anorexia, perfectionism, preoccupation with the thin ideal, and they might miss other risk factors. In addition, the patient, if they meet BMI criteria for obesity, the doctors might feel more comfortable and trained recommending weight loss or discussing risk for type 2 diabetes. So just at the end, I wanted to go over just a few treatment considerations. I know we might have some folks who are clinicians in the room, and just give you some things to consider, especially when we're setting an atmosphere, right, to help folks and think of things that we might need to consider. So I love in our community, we call this the Purple Book, and it was written by two eating disorder clinicians, Black women. They edited this book. And they talk about the importance of asking hard questions. So different assessment questions than is typically that folks are probably trained to ask. But you look at these assessment questions and you see you're bringing in issues of race, culture, their hair. These are things that might affect our women. But because other clinicians don't know to ask about them, these might have huge effects on their eating behaviors and triggers to eat, but to bring in some of these questions that might allow you to experience a deeper reality from the people that you all get to serve. We also recognize that a comprehensive assessment, I know everyone gets a training, but you recognize we might need to include some other things based on what we know about women of color, consider the cultural implications of food, acculturative stress, asking if they're experiencing that, assessing for food insecurity, past history of trauma, their experience of cultural biases and beliefs. These are things that are going to be essential tools when we consider how we're going to really make room for folks to bring in their experiences and bring in their stories. when we think about the main psychological treatments for eating disorders, these are the main ones, especially the ones we have the research literature on. So cognitive behavioral therapy enhanced, I'd say this would probably be termed the gold standard of our eating disorder treatment. Family-based treatment is another wonderful model that has been used to bring in the whole network, especially when treating folks who are navigating anorexia nervosa, adolescents. And then we also have dialectical behavioral therapy and interpersonal therapy. And I put behavioral weight loss on here. I know that might be controversial, but there's a good literature that shows that when folks are engaging in treatment for weight management, it can help them reduce their binge eating per the literature. And so, and this is another way that folks are engaging in treatment for disordered eating. And so there's these two models I want to end with. And I have models for Black Americans and the Latinx population. And I think it'll just give us an idea when we approach our interventions and to think about a systemic approach, right? Instead of looking at the individual, because we are all in this system. And so when you think about for Black Americans, you look at the individual and providing support, right, for their experiences of stress and racism and increasing awareness of eating disorders, because due to stereotypes, it may not be aware that, they could develop eating disorders. On the family level, it's thinking about what did food mean in your family and some of the expectations around eating that were provided. And then when you think about providers, on that level, helping them realize it may not just be the over-evaluation of shape or
What it
weight.
means when someone asks for a special transfer?
Oops. Uh-oh.
Is that like some?
Oops. Evaluation of shape or weight. And then the system level is recognizing that we need to expand treatment for eating disorders in primary care settings, because these might be the very places that Black Americans, they go the most to get help, not the specialty eating disorder clinics. Okay, and so when we think about the Latinx population, what we see is in this red bubble, under similar things, providing education, psychoeducation to reduce the stigma of having an eating disorder, right? And then in the gold, the family is such an important part and often in this culture, and working to involve the family and giving folks the tools to support a family member who's struggling emotionally. And then helping our providers understand and be aware of eating disorders in Latinas and giving background and assessment tools on the treatment specifically in these groups. And then you think about just the practical things like providing folks transportation, thinking about maybe their concerns with immigration, their concerns, their fear of actually being connected to a provider network. And then providing sliding scale or some things that can also be helpful. So in conclusion, when we think about what we're learning, we have limited evidence. I hope that even though I went over a couple studies, these are few compared to the other studies we have in other groups. We have limited evidence, y'all. And we recognize that while we're learning that there are a lot of similarities when eating disorders show up and when folks are navigating them, things might look different for the factors that might get folks to the table, might get folks to the door. And so we recognize their disparities in service utilization. So we may have to make changes in the setting, how we recruit folks, how we incorporate culture in our treatment to make people feel comfortable being there. And so in conclusion, what we know, there's a similar prevalence. That's what I want y'all to walk away. Across racial and ethnic groups, there's a similar prevalence of eating disorders. And we have disparities in access and retention to treatment. Poverty, racism, and stress may also contribute to the development of eating disorders. And so we're going to need more evidence, though. We need more evidence on strategies to reduce these disparities and to create different treatment experiences for Black and Brown women. And so we're looking forward to continuing this work. So thank you all so much.
Thank you, Dr. Goode, for sharing this evidence on such an important topic. It was really remarkable, some of the data that you showed. We're going to hold questions until after Dr. Bhatnagar's remarks. Dr. Bhatnagar is a clinical psychologist who has specialized in the scientific study and treatment of eating disorders and related psychological conditions for over 15 years. She completed her undergraduate and graduate studies in the Department of Psychological Sciences right here at Case Western Reserve. And then she completed a clinical residency and postdoctoral research clinical fellowship at Children's Hospital, Colorado, where she gained specific expertise in pediatric eating disorders. Dr. Bhatnagar has a faculty appointment in the Department of Psychological Sciences here at Case, and she is a consulting psychologist at the Laurel School Center for Research on Girls. She is one of 2 therapists in Ohio formally certified in Maudsley family-based treatment through the Training Institute for Child and Adolescent Eating Disorders. Dr. Bhatnagar is currently serving as the president of the Academy of Eating Disorders, and in 2018 was named a fellow in the Academy, given her recognition for distinguished contributions to the field of eating disorders. Dr. Bhatnagar, thank you for joining us today. You can go ahead. Slides.
Share my slides. Okay. Thank you so very much for having me. I am thrilled to be here to talk about a topic that I feel very passionately about for so many reasons. And it's truly an honor to present alongside Dr. Goode, who has just done such wonderful research in this space and really helped make a lot of very difficult research digestible for clinicians. So thank you to Dr. Goode for that amazing presentation. So in my professional life, I wear several different hats, but I'm excited because today I get to wear the hat of clinician, whereas Dr. Goode got to speak to the research side of things, I really now get to speak to the practice side of things. And I get to represent the voice of Cleveland and Northeast Ohio as well, being a local person. So my talk is going to be, and my thoughts are going to be on how do we tailor evidence-based treatment models for Black and Brown youth with eating disorders from a clinician's perspective. So I'll start by talking a little bit about the local scene. What have we been seeing here in Northeast Ohio since the pandemic regarding eating disorders? I want to introduce a little bit about current gold standard treatments for adolescents, which is Maudsley family-based treatment, and give a brief overview of that. So before we can talk about how to adapt our evidence-based treatment models, it's important to have an understanding of what they actually are. And then through a case presentation of an adolescent that I actually worked with, I want to talk a little bit about where these evidence-based treatment models fell short for one Black and Brown girl that I worked with, and I'm sure many other Black and Brown youth. Finally, I'll end by just offering a few more considerations for using FBT in particular in BIPOC populations. So a little bit about our practice. We're located in Beechwood, Ohio, and we are a center that's really specifically designed to treat eating disorders and related psychological conditions. We have a multidisciplinary team that's composed of psychologists, professional counselors, social workers, dietitians, and we have community partnerships with specialist physicians and psychiatrists. And we also have an in-house graduate student training clinic where we offer training to, right now it's doctoral candidates, but next year we'll be adding in social work and professional counselor students as well in how to treat eating disorders. But our main focus is the outpatient management of eating disorders. After years and years in working in residential and higher level of care facilities, I really have become passionate about, what can be done at home, keeping a child in their home, not in hospitals, not in residential facilities, and really encouraging the family to step in and to be able to help out so that we can keep the kids involved in their lives and in their community. So we focus on the outpatient management of eating disorders across the developmental spectrum. So who we serve youth, families, and adults. Our youngest kiddo here is about age 5, and our oldest is a woman who's in her mid-60s. I would say our primary demographic, however, are those between the ages of 12 and 25 years. That's who we tend to see the most here in our clinic. We serve people mostly in Ohio, but we do have, and all across Ohio, but we do also see clients in other states that are part of the SIPACT agreement because we're able to offer virtual appointments. Our clinic, we feel very passionate about reducing barriers to be able to offer care to people from all walks of life, including all genders, all ages, races, ethnicities, body shapes, and weights. So we had to find creative ways to be able to do that. So we do offer a reduced fee and pro bono treatment for those in need. We offer also reduced fees through our in-house student training clinic. We have a partnership with Project Heal, which is a nonprofit organization that can offer grants and helps identify those experiencing barriers to seeking eating disorder care. It helps them identify providers, and by offering virtual and in-person appointments to decrease transportation barriers. And my caseload in particular, because I am unfortunately, one of the few women of color or therapists of color in our community that specializes in eating disorder, I do tend to see a higher percentage of girls and women of color with eating disorders. And so again, I'm going to be kind of representing that in treatment today. So what have we seen in about eating disorders in Northeast Ohio since the pandemic? So not surprisingly, everything that Dr. Goode was talking about in her presentation, what we know is that eating disorders all over just skyrocketed. And for our clinic in particular, it was really interesting because we opened the doors to the Center for Emotional Wellness in 2020, just maybe not too long after the stay-at-home orders were released. So we didn't know what to expect in terms of client care at that time. And we were shocked to see the number of people that were reaching out, that were seeking support, especially for their kids and teens, to help them manage the pandemic and the isolation that came along with it. And, also having to care for others and provide that to support for others while we were all also adjusting to the changes related to the pandemic. And so including having to rapidly adapt our treatment models and our services for virtual delivery. So it was a time, what I call a time of chaos for most clinicians in this area. What we saw, though, is that eating disorders at that time, similar to what Dr. Goode was saying, there was a significant impact on the physical, emotional, and social well-being of our Cleveland youth. ER visits were, for eating disorders doubled at the time. And what our teens were reporting was an increased social isolation and over-reliance on social media for connection. Now, we all know many teens who call themselves addicted to social media. It got even worse. And to a certain degree, it had to, because our teens had less access to their social supports. They didn't have the routines that they used to that helped them to feel connected. And this made them feel more vulnerable to eating disorder behaviors. In addition to having to rely more on social media, this also meant that our teams were exposed to more images and other ads and things like that really increased body insecurity. It made our teens feel more self-conscious. There was also a lot of exposure to these messages to be productive. Since we're at home, now is a great time to lose weight, exercise more, which put an extra sense of pressure on people, an extra focus on body-related issues at that time. What we also saw too in our clinic is that eating disorders didn't discriminate. Similarly, just as Dr. Goode was saying, I love that public service announcement. You cannot, eating disorders don't look one certain way. They didn't discriminate. And we were seeing eating disorders in lots of different populations at that time. So Dr. Goode already mentioned some of the standard therapy treatment models. Adolescent focused therapy is an individually based adolescent model, CBT, DBT, and there's also specialist supportive clinical management. But this talk is going to focus primarily on Maudsley family-based treatment, FBT, since it's a child and adolescent focused talk. So to truly understand FBT, it's important to understand the historical context in which the model was developed. So in the 1800s, this was a time where there was a big interest in treating eating disorders. Although eating disorders had been around and identified, long report documented in scientific journals and case reports, this in the 1800s represented a time of interest in treating eating disorders. And the zeitgeist or the spirit of the times, not just for eating disorders, but for many forms of mental illness, was what we call a parentectomy model. There was a blame being put on parents, mamas in particular, saying that families are somehow contributing to the mental health struggles that kids were seeing, and eating disorders were included in that as well. So there was the clinicians at the time would advocate for what we call a parentectomy model, which means separating the child from their family, from their community in order to receive treatment. And so some of the most prominent physicians at the time, Sir William Gall, a prominent English physician, was quoted as saying, "The patient should be fed at regular intervals and be surrounded by persons who would have moral control over them, relatives and friends being generally the worst attendants." Charcot, who the father of neurology, a French physician, was also quoted as saying, "It is necessary to separate both children and adolescents from their father and mother, whose influence, as experience teaches, is particularly pernicious." Now, I have no shame in admitting when I first heard that quote, I had no idea what pernicious meant. So when I looked it up, I actually saw that it meant evil or wicked, which is a really powerful word to describe, the role of parents and families and in relation to kids struggling with mental health illnesses and eating disorders too. But they were being separated and sent to asylums or residential facilities where parents had no involvement whatsoever. And they were coming back from these facilities then when parents were feeling as if we have no idea what to do. My child was sick, and yeah, some weight got restored, because they were being supervised by other people or under the threat of feeding tubes, but we don't know what to do. So even though that was back in the 1800s, nowadays many clinicians still believe that effort should always be individually based. And in fact, some strict adherents of the individual therapy model will insist that participation of parents is at best unnecessary and at worst run significant interference with the recovery process. Further, family problems are still considered part of the etiology of the illness, which we now have a better research to talk about the etiology, but this also contributes to a sense of guilt and blame expressed by many parents. So FBT opposes the notion that families are pathological and should be blamed for the development of eating disorders, and instead considers parents and families to be the best possible resource for recovery and essential, in fact, to the successful treatment of eating disorders. So when Maudsley was developed in the late 1970s, a group of researchers at the Maudsley Hospital in London got together and said, look, what are we doing here? We would never say to a kiddo or family of a kiddo with cancer, send your kid off by themselves. Parents, you should have no involvement. You should have no understanding of what's happening. And then when your kid is well, we'll send them back. So the researcher said, no, in fact, what we would do is we would encourage parents to be decision makers, to teach them how to hold, support their child when they're struggling, when they don't want to go to their chemo appointments, how to administer their necessary medications at home, So parents were an active part of the treatment plan. So the researchers at the Maudsley Hospital said, what if we take that model and map it onto eating disorders, really trying to keep kids embedded within their lives and in their schools, and then teach parents the skills that they need to help us manage the eating disorder, and let's see what the outcomes look like. And since then, with the timeline in 1994, there was a more adolescent focus on FBT when it was brought to the U.S. and more adolescent focused research. And then in 2001, the treatment manual for anorexia nervosa was published. That's the first edition. 2007, the bulimia counterpart was published. And in 2012, the second edition of the AN treatment model was published. So in this model, the goal is really about health restoration, weight restoration for kiddos with anorexia, and getting a kiddo back on track to return to their normal adolescent developmental trajectory. It's intended to last from 6 to 12 months, about 10 to 20 sessions. And there's evidence for having a conjoint model where both parents are involved, or the parents and the kid are involved in the session, or a separated model where parents are just working with the clinician alone. But important things to note about the model is that in this treatment model, we take an agnostic view of the etiology. So we're not spending a ton of time in session focusing on the root cause, because it's so complex from what we know about the etiology of eating disorders that we're wasting time and a kiddo can become more ill as we're trying to find the root cause. So instead, we're really focusing on what's maintaining the illness in this moment. And there's a heavy focus on the behavioral aspects of the illness and what behaviors we need to change. We teach parents a skill called externalization. It was teaching them to separate their child from their illness. We encourage parents to take a firm yet really empathic approach to the illness too. And all family members are strongly encouraged to attend all sessions. There are 3 phases of treatment in FBT. Phase 1 is typically intended to be sessions 1 through 10. And in this phase, we are laser focused on restoring the child's health by putting the parents in charge of what the kiddos are, for grocery shopping for the kids, for determining what they're going to eat, for plating their meals, and for supervising all of the meals and all of their activity. And if a kiddo is engaging in purging, supervising restroom breaks or having specific restroom breaks for that time. So we're really empowering parents to step in and take control here. And as you can imagine, most teens absolutely hate the idea of this. It kind of goes against what we think of in terms of adolescent autonomy, But at that time, most of the time, our kiddos just are too sick to be able to make the decisions that they need to. So we need those who have their best interest at heart to step in and to be able to take control until they're able to do so. That's when we move to phase 2 of treatment. And this phase is all about returning developmentally appropriate control back over to the adolescent. I always joke with my families, you can't go off to college with your kiddo and fry up their eggs in the morning. So at some point, we have to teach them how to be able to do that themselves. So we have a very planned out, thoughtful way of being able to return control back over to the adolescent of their meals and of their activity. And our phase 3, this is what I call our how do we get here in the first place phase, where we're really focusing on relapse prevention, understanding kind of some of the risk factors that led to the development of the eating disorder, and then talking about other issues in relation to adolescent development. So quickly, research on FBT. Right now, for adolescents, anorexia nervosa in particular, there is evidence to support FBT for anorexia, bulimia, ARFID, and binge eating disorder. But right now, it's considered first-line treatment and gold standard treatment for adolescent anorexia nervosa, and it's been systematically studied in 9 randomized controlled trials. It's demonstrated itself as a robust evidence-based treatment for adolescents with eating disorders. Approximately 2/3 of adolescents with anorexia can recover by the conclusion of FBT, and 75 to 90% were fully restored at 5-year follow-up. There's adolescents with anorexia who receive FBT recover at higher rates than adolescents who receive individual therapy. And in particular, for anorexia nervosa, early weight gain, so gaining 4 pounds in 4 weeks, is a really strong predictor of remission. We have an 80% chance when that 4 and 4 goal is met. So really making sure that we're restoring weight early on is very important. But we are working within a 3-year window of opportunity. So early intervention is critical to outcomes. And finally, what we know, families that rate low in expressed emotion and in expressed criticism tend to have better outcomes, which will be important for our next part of our talk. So with this, we think this looks great for FBT, right? So there's a lot of support. Research is showing that it's really helpful. But what about folks that are underrepresented or unrepresented altogether in research trials? Like Dr. Goode mentioned, there's this common misconception that eating disorders are white women illnesses, and not just white women illnesses, affluent, straight white women illnesses as well. So, but that misconception, as we learned from Dr. Goode, is just not the case. We did see that the overall presence of eating disorders is similar across racial and ethnic groups. And there's some evidence to suggest that certain EDs and behaviors are more common among BIPOC individuals. Dr. Goode talked to us about the stress and trauma associated with systemic racism and marginalization that make BIPOC individuals especially vulnerable to eating disorders. And that includes our youth as well. Yet, BIPOC youth are less likely to be screened or offered referrals when presenting with eating and weight management concerns. So as a result, they're often going undetected. So as a case example from here in our hometown of Cleveland, meet Danny. Danny is a 16-year-old Black female who used the pronouns she, her. She's an 11th grader at a local independent private school who is there on full scholarship after being in public schools for the majority of her life. What's important to note is Danny was one of the few students of color in her class and really had a difficult time feeling comfortable in this new school environment, making connections, feeling as if she could find a good friend group in this new school. But when she first got there, she was doing well academically, just felt very socially isolated. Danny lived with her mother, who was employed full-time and had a very inflexible schedule due to her job. She also lived with her grandmother, who was struggling with a chronic illness, and 2 younger siblings, ages 12 and 9. Danny was recently, at age 16, diagnosed with anorexia nervosa, despite exhibiting clear symptoms, since the age of 14. The symptoms that she had been exhibiting was there was a significant weight loss. There was a drastic deviation from the typical growth trajectory that was seen on her growth charts. And this had been on the radar of the pediatrician for quite some time. Danny was engaging in restrictive eating, purging, reported extreme body dissatisfaction, felt really socially isolated, but yet still showed a lack of insight into to the seriousness of the behavior she was engaging in, therefore resulting in low motivation to participate in treatment and to make any changes on her own. Danny also had some symptoms of depressed mood as well. It's also important to note that although there had never been any formally documented eating disorder in Danny's family, there was a robust family history of funny eating, but again, no diagnosable eating disorder. So with Danny's illness trajectory at age 14, she was told by a pediatrician she had to lose weight because her BMI was too high. Now, we know that BMI can be considered a flawed measure. I know it's one of our only ones right now, but it can be considered a flawed measure for particularly of a flawed measure for health status, particularly for people of color for various reasons. But because of that, the pediatrician told Danny that she needed to lose weight. They also recommended an organic Mediterranean style diet to the family, and they were advised to eliminate many of their standard meals and foods that the family enjoys, particularly over the holidays. After a while, this was just not sustainable, and the family was not able to afford what the pediatrician had been recommending at the time, and then eventually stopped visiting the pediatrician due to fears of being judged and a distrust of the advice that was being offered by the pediatrician. Meanwhile, Danny was watching many TikTok videos that were focused on weight loss and found these pro-Ana websites that were all highly supportive of the thin ideal and standards of beauty that didn't quite match how Danny saw herself and Danny's perception of herself. Wasn't it all inclusive of Black girls and women? But Danny still admitted to being addicted to watching these videos throughout the pandemic. Mom became increasingly concerned about drastic and rapid weight loss, but when she took her back to the pediatrician after some time, Danny was actually praised for her weight loss efforts during the visit. And during that time, there was no screening for an eating disorder done at all, and the eating disorder behaviors continued. The school noticed a decline in grades, less social engagement, and referred her to a clinician for therapy. And there, Danny was diagnosed with depression. Again, no screening for an eating disorder done at that point. Danny continued to lose weight over the next couple of years due to restriction, over-exercising, and purging. She fainted at school during gym class and was hospitalized immediately for bradycardia and orthostasis, admitted purging to an attending doc, who then called for an eating disorder consult when Danny was finally diagnosed with anorexia nervosa. So in her treatment experience, despite protests due to cost and time commitment, the family was forced into entering a program to treat Danny's eating disorder, a PHP program. And the family was under the threat that the hospital was going to call Child Protective Services on them if they didn't participate in this. When Danny started her treatment program, she was the only person of color in the treatment program, and there were no clinicians of color and very few administrative staff, support staff of color. So once again, Danny was in an environment where she felt isolated, where she felt she didn't see many people that looked like her and felt uncomfortable, and especially with opening up about something so private that she really didn't talk much about with her family with either in this treatment environment. FBT was a required part of treatment in the program. And during one of the FBT sessions in this program, per the FBT model, with parents bringing in the food and supplying the food for treatment, Mom was tasked with the role of bringing in Danny's food, but Mom was criticized for supplying fast food for Danny's meals. And the clinicians were saying that this wasn't balanced, and why was Mom bringing this? And she's really bringing other things into the treatment program. Also, it became increasingly difficult for Mom to miss work to attend the FBT sessions. And further in sessions, Mom was told to stop being so authoritarian and be more understanding when feeling frustrated by the illness. Mom was coached to use externalization, which I described, to manage frustration, but she refused to do so because it made Danny sound crazy. That was telling her, what, that's not my child. It's a little alien living inside of her that's making her act that way. No, that makes my child sound crazy, So that wasn't a helpful strategy for her in FBT. Danny struggled with engagement in group and became more willful during meals, which is not uncommon at all in eating disorder treatment. But instead of this being addressed as a symptom of the illness, Danny was required to attend adjunctive individual therapy sessions that focused on anger management skills, which again made Danny feel even more isolated and feel even more different than others in her treatment group. In body image group, Danny was told her body dissatisfaction was solely a product of invalid negative thinking. And we could use cognitive restructuring so you could easily become at peace with your body without any sort of acknowledgement of the difficulties that Black and Brown youth face and the different, when trying to achieve the standards of beauty that just aren't meant for them. So body image group in particular was a significant struggle for Danny. What was one really embarrassing incident for Danny, she was required to move her headscarf that she wore one day. She didn't have time to do her hair. She was very embarrassed about that. So wore a headscarf to treatment that day and was required to take it off because hats were not allowed. So Danny, there was a session where she spent so much time talking about the shame and the embarrassment that she felt having to, her hair looked so different and not feeling as if she was able to do her hair, and her headscarf being referred to as a hat. When Danny was unable to restore a meaningful amount of weight, Mom discharged Danny EMA, but agreed to seek outpatient treatment at the counsel of her pastor. Mom's one contingency was that the clinician had to be Black. So all the red words and phrases that were, as I described Danny's treatment trajectory, was really where our standard assessment and treatment models fell short for her. I knew that we had to somehow bridge the gap, make some adaptations to our standard treatment model in order to make this applicable for Danny and her family. So some changes that we made to the model, as in FBT, offering psychoeducation to kind of build the crisis, to get parents activated and motivated to take on the role of refeeding their child. You know, offering psychoeducation about eating disorders is a big component of it. Yet, you know, in most of our evidence-based treatment manuals, there's not a lot of psychoeducation about that specific to BIPOC individuals. So Danny and her mom were surprised to hear about the prevalence rates of disordered eating in non-white communities. And as we encouraged Mom to elaborate on funny eating seen in family members, it dawned on Mom that other relatives likely also struggled with a disordered eating. We acknowledged the different sociocultural factors that shape eating disorders in Black and Brown communities. Danny's, once said to me, I can't be fat and Black and fat at my school. I already don't fit in. And then if I'm fat, that's 2 strikes against me. So for her, there was a safety in conforming to what societal expectations demanded of her. And this kind of explained her unwillingness to change. So the PSA for Dr. Goode's announcements, ask those purple book questions. We addressed cultural differences in family dynamics, and in many Black and Brown households, parents can play a more authoritarian role. So FBT needed to better affirm Mom's authority while also encouraging communication and reduction of critical statements. We used a refeeding plan that incorporated more familiar foods for Danny and her family and more sustainable and affordable foods. We had a long conversation about how BMI could be considered a flawed health metric, especially for people of color. We talked a lot about cultural stereotypes and how willfulness is now seen as a symptom of the illness, not a sign of an angry Black girl, as Danny perceived and her mom got the perception from previous treatment. And we leveraged trusted community resources, involved her pastor in some of the FBT sessions. The first lady of her church and the church sisters assisted with meal supervision when the mom had to work. And we really did a lot of problem solving to break down barriers, transportation barriers, by offering virtual sessions when necessary. So with that, I'm pleased to say with those interventions, Danny it was not easy whatsoever, but Danny is actually thriving today and actually does some education and leads some support groups right now for other BIPOC individuals struggling with eating disorders, and which she's found to be very fulfilling. She's considered fully health restored at this point, and her eating disorder has been in remission based off of these adaptations that we were able to make to our current evidence-based treatment models. So with that, my final PSA announcement would be cultural consciousness really broadens the reach of evidence-based care. So we need to incorporate these considerations when we're thinking of treating Black and Brown youth with eating disorders. Thank you.
Thank you, Dr. Bhatnagar, for that really interesting case and thankfully a successful outcome thus far. We're going to go ahead and ask both of our speakers some questions to get us started, but please go ahead and add your questions to the chat or the Q&A, and we'll make sure to review those and get those asked as well. I'm going to start us off though, so this is for both of you, but I'll start with Dr. Goode. Even in promoting this event, we received just offhanded comments like, oh, this isn't really an issue in Black and brown women. Why are you hosting this event? What steps can we all take away from this talk today to change the narrative on eating disorders for Black and brown women? And we haven't actually mentioned men at all too. Is there, anything that we need to move forward on with men of color as well?
Yeah. Oh, this is so real. I think one thing that I have seen that actually has been really helpful is when folks are brave enough to share their stories. Because when you recognize that someone who looks like you, who you respect, you admire, has come out and said they struggle with disorder eating, it just creates the space for you to be able to share your story. I think representation matters. I remember when Ed Sheeran, he came out talking about his disordered eating, and when other folks, I think of Stephanie Covington, have written articles, there's just been more and more people. And so I think part of it, when folks say that, I think it's just a product of ignorance. I know no one's, there's any harm intended, but we just don't really have a lot of examples. And I know for me as a researcher, one of my goals is just to continue to give us some evidence so that clinicians have some tools to work with, that they can begin to have some different interventions, some different tools that we can know. But I think we're going to have to, it might be a grassroots effort at first, but hopefully as we continue to grow as researchers, as we continue to work on a systems level to change it, we can together change the narrative.
And do we see eating disorders in men of color as well at the same rates as in
not the same rates, not the same rates, but if you want to talk about limited evidence, we have such limited evidence. So I don't even know if I could really even speak authoritatively about it. But what I do know is the rates are not the same, but there's so many things that get in the way. One thing we are learning more about are the role of disorder eating in athletes. People, especially folks who have to make a certain weight for their sport. We are learning more and more about it, but I would say the literature is just not there yet. So we don't have, I know from a research perspective, I don't have much to contribute on that.
Thank you. And Dr. Bhatnagar, how do we support the adolescents who may be emerging, right? Eating disorders may be emerging at that time period, but they don't feel seen by their communities, by their school nurses, by their parents. How do we support, promoting awareness for this issue, for emerging eating disorders?
Great question. I think a lot of what Dr. Goode said, representation is so very important. And I think in order for these youth to feel comfortable talking about eating disorders or disclosing any disordered eating behaviors, they themselves have to understand, that this actually happens in Black and brown communities as well. I know many schools are working to adapt their health class curriculum to, make sure that images, when they're showing images of adolescents with eating disorders, that it's not just the stereotypic thin white, a teen girl that's being on there, and making sure that the health class curriculum is being inclusive. Sorry, it just changed me. Making sure that health class is being inclusive of statistics and information specific to BIPOC individuals as well. So I think a lot just educating and creating safe spaces to be able to talk about it. Particularly, I think the schools and pediatricians are first line of defense of being able to make some changes.
Okay, that's helpful. Thank you. Dr. Minnis, do we have any questions from the audience that you want to highlight? You're on mute.
Sorry about that. Yes, I have a question. Has to do with, again, this idea of prevention. We talked about, family and teachers. I wonder if either of you have thoughts about particular policies that, we always talk about it taking a village, right? It's not just our pediatricians and our families and our teachers, but what types of policies might be implicated in providing this type of prevention and really early, you talked about this critical need to get fast intervention. Yeah, so
Yeah, that's a great question. And I think we have been, so on the policy level, we have seen more movement. You'd be surprised, eating disorders is considered bipartisan, so that has been encouraging. And so most recently, we saw the passage of I think it's the Anna Sweeney Act, which allowed for the development of the National Center of Excellence for Eating Disorders. And so that provided 5 years of funding so that we could have a place where folks could go centrally located that's funded by the government to provide training that folks needed to kind of curate the information. So all of the key content experts, we were required to review like tons of stuff so that when folks come to our site, they know that this information has been reviewed by experts, right? And we take it seriously. And then we have free trainings for folks so that we can begin to expand the knowledge. I think of the Eating Disorder Policy Council, right? That's their whole job, is to make sure that we are translating what we know, and we're getting this on the policy level and being able to kind of insert ourselves when we can. I think about most recently when President Biden had the conference on poverty and hunger for the first time in years. Eating disorder clinicians, eating disorder researchers, we were a part of the conversation. And I know I was bringing up information about food insecurity and just about some of our policies related to the distribution of SNAP benefits. And if there could be another way, considering the current, I know no one intends the harm, but the current model, even if benefits were distributed twice monthly, it would make it a bit easier for our families to begin to manage the resources that they need to begin to help. So I find that we're working, trying to get out there and trying to make some headway as best we can, but we just need more of us. What we care about is going to our Congress people and telling them what we're concerned about so that they lobby and we get what we need.
Yeah, thank you so much. I have another question here from the audience. It says, I'm wondering how the Kids Online Safety Act would help with cases like Danny's, where social media is impacting disordered eating. I'm not sure where that's at currently in legislation, though. Is that?
Yeah,
No, I was just going to say,
No.
is that something that either of you can comment on?
Go ahead, Dr. Kelly.
No, I was going to say, I'm not quite sure where it is right now in legislation. However, I do know many of the large eating disorder professional organizations and family support organizations have been doing a lot of advocacy, signing letters to sign on to show support for the act as well, because we all feel that it would be incredibly helpful for kiddos like Danny in managing eating symptoms.
So helpful.
Yeah, and Gabriella Celeste, our policy director, she just put in the chat that it was just introduced so far, and she put the link here for everyone
Thank you.
who might be interested. I have another follow-up question. Basically, it's two. They might seem a little bit separate, but one was about if you're familiar or you've seen efforts through the school-based health services to be involved in early detection and early treatment. And then the other, you mentioned athletes being at particular risk. And I'm also wondering, I know there's some correspondence between, it goes sort of in either direction, but eating disorders and also substance use disorders.
Mm-hmm.
And I'm wondering if you have any comments about how that might play a role in our Black and Brown youth.
Mm-hmm. Well, what I know about eating disorders and substance use, I feel like it's like a similar broken record. There's not enough help. And often what folks who are managing a substance use disorder, they're having to choose between, are they going to get treatment for the substance use or they're going to get treatment for the disorder eating? It's very, very difficult. We actually don't even have a treatment model where they're combined. And so it's very, very challenging. And there's not even the guidance really of how to kind of navigate that in a clear evidence-based way that we have replicated in research. I know clinicians are out there, you know, being all-stars as they always are, but we don't have a lot of guidance in relation to that. And so it really creates opportunities, I think, for folks to fall through the gaps, right? Knowing that sometimes folks are managing some of the factors that maybe affect the development of disordered eating through the use of the substances. And so they kind of go together as folks are coping with the realities that they're facing on a daily basis, trying to, you know, kind of deal with anxiety, manage their depressive symptoms, past trauma. So we know all of that's related. So I'm hopeful that we can begin to move forward, but there are some incredible gaps right now.
I think we had a question in the question box. This is for both of you. Are weight loss programs like Weight Watchers considered a treatment model for people with eating disorders? Is there anything we can learn from that approach that has such wide scale?
I'll talk about that.
Go for it.
So no, that would not be considered a treatment approach. If someone has an eating disorder, the first thing that needs to be done is the treatment of the disordered eating. However, because there are holes in our system, folks aren't getting, you know, screened. They aren't getting the recommendations, the help and support they need. And we talk a lot about weight loss in our country. Folks with disordered eating will go to Weight Watchers. And, you know, and what we see in the research literature is that for a certain subset of those folks, they might have some improvement, right? But that doesn't mean that based on what we all know, the eating disorder needs to be treated first.
Thank you. Thank you for that clarification. Kelly, do you want to?
Sure. I was just going to say, I second everything that was just said right there, you know. And what I might add in as well is there now is a lot of attention being put on weight loss injections, such as, you know, Ozempic and whatnot. And there's a similar mindset for that as well. They're counterindicated for folks with eating disorders, can cause more harm for people with eating disorders too. So again, why it's so important that we're screening before recommending these weight loss interventions that could have grave danger for folks with eating disorders.
Yeah.
So to follow up on that, it seems like for our adolescents, the screening needs to be done in the pediatrician's office, right? And that's where a lot of these individuals are getting missed because of their BMI. So what steps need to be taken to train our medical providers to flag this in a better way than what's being done now?
Yeah, one thing I'm excited about is that NSEED, we have just developed SBIRT, which is the SBIRT for eating disorders. It's a brief screener based on the SBIRT model for substance abuse that is accessible, you know, so folks can go on there and we talk to pediatricians, primary care physicians to learn how to create it. And so it's there. And so folks can use it, even if they don't have any knowledge, because I know folks have said, I don't know what to do. I haven't gotten any training. Well, you can just follow. We'll tell you what to do next, you know, just a brief screening so that you have the tools. And so we've worked hard on that as a center. Our director, Christine Pete, they did a whole study about it and now it's up and ready. So folks can use it.
Great.
Yeah, and in addition to that too, I just want to say, you know, we're very fortunate to live where we do in the Cleveland area, you know, to be able to have some of the experts that we do in eating disorders. And when we're thinking of medical education, I saw like my colleague, Dr. Ellen Rome, is actually at this presentation too. And Dr. Rome is just a phenomenal physician and a supporter and an advocate in treating adolescent eating disorders, and has made great efforts to educate our community on the medical management of eating disorders. So we have some great resources here locally as well. And also too, there are professional organizations. We're now also working to disseminate more information that's appropriate for primary care, for pediatrician offices. There's another purple book, so not the purple book we were referring to earlier, but the Academy for Eating Disorders has something that they call the purple book, which actually is a brief guide to medical interventions for eating disorders. Actually, I think Dr. Rome was one of the authors on that book as well. And so it's very it's free online, easily accessible. They have a nutrition counterpart. They have a psychological intervention counterpart too that you can get from the websites that got a brief screening, screening tools, considerations, and whatnot.
Thank you. Thank you. That's really helpful. We are at time. I was going to say, do we have time for one more question? And I don't know that we do. I think we were so thankful to both of you for presenting today and for sharing your knowledge out with us. And I hope that as an audience, we can, leave here and take more awareness and information to our stakeholders and who we work with, so that we can move the needle on this a bit since hearing this important information. So thank you to both of you. Thank you, Dr. Goode, for joining us from Chapel Hill. Thank you, Dr. Bhatnagar, for joining us locally and telling us a little bit about our adolescents in the area. And I thank everyone else for joining us on the call. We will have a recording of this talk on our website as soon as it's ready, and we'll make sure to get that out to all of you. So thank you. Enjoy the rest of your day.
Thank you.